Mm-hmm. All right, welcome everyone. Thank you for joining us today. So we have an exciting joint talk scheduled by Dr. Mika Kontro and Heikki Kuusanmaki. Apologies on the pronunciation, obviously. Dr. Mika Kontro was a specialist in internal medicine and clinical hematology, and he was a co-investigator in clinical AML studies. His research is focused on novel drug screening and sequencing technology to individualize therapy, particularly for acute leukemia and subtypes of leukemia. He comes to us from the University of Helsinki and the Institute for Molecular Medicine of Finland. And so does Dr. Kuusanmaki. Dr. Kuusanmaki completed his PhD in September 2018, looking at key survival signaling pathway for the treatment of leukemia. His main discovery was the identification of STAT5B mutations in a couple of rare leukemia subtypes. And during his PhD, he developed a very exciting flow cytometry-based drug screening platform, which is used to determine primary AML sensitivities at single-cell resolution, which is now a platform used to predict treatment outcome in leukemia patients. If you want to share your screen, let's make sure that's working still okay. And then we can get you guys started. I like that your desktop looks a bit like mine. And the talk today, I know, yeah, we see your presentation now. The title of the talk today is Predictive Value of Ex Vivo Sensitivity Testing of venetoclax in AML. Thank you so much.
Thank you, Alice, so much for the kind invitations and good evening here from Helsinki. So we'll be discussing about venetoclax in AML, and I do know that for most of you, the background here is already well known, but just very few words in the very beginning. So as we do know, anti-apoptotic proteins are commonly overexpressed in cancer. And what we actually aim to do with BCL2 inhibitors or BH3 mimetics, we are detaching these pro-apoptotic proteins from their anti-apoptotic counterparts, enabling them to localize on the mitochondrial outer membrane, which then leads to permeabilization of the outer membrane, and this in turn leads to cytochrome C-mediated apoptosis. The treatment challenge for us AML hematologists has been for a long time what to do with the patients that are unfit for conventional chemotherapy. And traditionally, we have been treating these patients with azacitidine. And I do have to admit that the treatment responses have been quite poor. Approximately 1/3 of the patients at most achieve CR or CRI responses, and the survival is just 10 months. When looking at the data from VIAL-A trial, which was randomized trial with ven-aza against azacitidine, it showed that with combination, the CR/CRI rate was 66%, and the survival was approximately 15 months. And of course, this is mainstream already in US, but in Europe, we are basically in many countries just waiting the national reimbursement policies to take place. When looking at the data from relapsed, resistant, or secondary AML patients, we actually don't have any randomized trials in this patient population. From a single-center trial from MD Anderson, we do have the data that for relapsed, resistant AML patients, HMA plus venetoclax produces treatment responses in 42% of the patients with survival approximately 8 months. And for those patients that had secondary AML and received previous therapy for example, MDS, the CR/CRI rate is actually quite similar, but the survival is a bit shorter. And with that, Heikki, perhaps want to continue from here?
Yes, thanks. So I think that I don't need to introduce ex vivo drug testing concept for this audience, but we think that kind of the three main factors that influence the process the sample? Are we using fresh or thawed samples? Are we using the whole mononuclear cell fraction, or do we enrich the blasts when discussing about the leukemia samples? Second, what kind of cell culture conditions we are using, which media, how many days we culture the cells, and third, that what kind of cell viability readouts we are using. So do we measure the bulk sample sensitivity with MTT, CTG assays, or do we use single cell based methods such as microscopy or flow cytometry? And if we dig a little bit deeper, so at FIM, we have mainly used 3 different cell culture medium. Could you, Mika, change the slide? So. Okay, so we have mainly used 3 different cell culture medium. So first, we have used RPMI supplemented with 10% of FBS. And earlier days, we also used mononuclear cell medium. And when talking about the cell viability and drug sensitive profiles, this MCM is very similar to RPMI, and we don't use it currently anymore. And then we have used this conditioned medium. So there, the human stroma fibroblast cell line, HS5, are cultured in RPMI, and after 72 hours, we harvest this medium, and these cells have secreted cytokines. And we know the cytokine profile quite well. So for example, it includes high concentrations GM-CCF, IL-6, GCCF, low concentrations IL-1B, and so on. And then this harvested media, we used 12.5% and added to the RPMI. And the third medium that we have been using is the commercially available StemSpan, SFPM2, and we have supplemented that with several different cytokines. But in the VENEX trial, we used stem cell factor, TPO, and FLT ligand, and these cytokines are commonly used to kind of culture healthy CD34 positive cells. And former PhD student Riikka Karjalainen analyzed the drug response profiles when the same primary AML samples were screened in mononuclear cell medium MCM compared to conditioned medium. And what she found out, that actually in the conditioned medium, the JAK inhibitor efficacy was much higher. So probably these cytokines activate many cell survival pathways through the JAK kinases. And in the other end, you see in the red box, so in the conditioned medium, the BCL2 family inhibitors don't work so effectively. And we know that if we deprive the cells from cytokines, they tend to be primed to apoptosis. And also the FLT3 inhibitors lose their effect in this conditioned medium. And then the third thing is that how we analyze this cell viability after drug treatment. So we at the FIM have mainly used cell titer glow. So it lyses the cells, and the more we have ATP, the more we get signal. It's fast, it's robust, it's cheap. But the problem there is that we don't really know that which cells the drug has killed. And for that reason, we also implemented this flow cytometry based approach around 6 years ago. And when analyzing these AML samples, we noticed 2 main things. So first of all, many of these primary AML samples, the cell composition is actually quite heterogeneous. And the second thing was that these different main cell populations like lymphocytes, blasts, monocytes, granulocytes, they have different response, they respond differently to drugs. Like for example, we saw that venetoclax usually kills the immature blast cells, but if the samples are also the monocytic cells, they don't get killed with venetoclax. And then a couple of words from the gaining strategy that we have been using. with the flow cytometry. So in the VENEX trial, we used antibody panel that can be seen at the next slide. Here on the right, and basically we gave the cells and we annexin 5 and 7, or by excluding annexin 5 and 7AD apoptotic and dead cells. And from these live cells, we are mainly interested in the blasts. And now the definition of the blasts is sometimes quite tricky. But when we talk here about the blasts, we mean CD34 positive cells. And approximately 70% of the samples, the blasts are CD34 positive. And if the blasts are negative for CD34, we have used CD117. And if the blasts are negative for both of these markers, then here we have used site scatter versus CD45 to determine the blast-specific drug responses. And on the next slide, we have illustration of one sensitive and resistant patient sample. So here, after 2 days, you can see how the CD4 positive viable blast cells are diminishing when we increase the concentration. And in these drug plates, we usually use 7 different concentrations for each drug. And then these are converted to dose response curves. And then they are converted to drug sensitivity scores. And basically, this metric is very similar to AUC, area under the curve metric. And the range is from 0 to 50, the higher value indicating higher efficacy of the drug. And then, as Mika mentioned, the venetoclax has substantially improved treatment outcome in AML. However, we don't really know that which patients respond to the treatment. And it is known that IDH2 mutated patients, MPM1, have a better prognosis for venetoclax, whereas TP53 and complex karyotype patients tend to respond poorly. But not all patients have these mutations, and moreover, the genetic alterations do not precisely predict the Ven-Aza response. So novel approaches are needed to identify those patients who benefit, and particularly in the relapse refractory setting. And there has been many publications. I believe that many of you have published also data showing nice correlation with these functional assays and with clinical responses, but usually they are all done retrospectively and with limited patient numbers. And for that reason, we designed a prospective trial to evaluate the usability of ex vivo drug sensitivity testing in a clinical context and evaluate the ex vivo in vivo correlation for venetoclax. And in addition, there were 2 other main reasons to run this trial. First of all, as Mika said, the venetoclax wasn't approved here in Europe before 2021. And through this trial, the patients got access to venetoclax. And second, during this trial, we collected well-annotated sample material that allows us to study venetoclax mechanisms and also identify additional biomarkers.
So as Heikki mentioned, the VENEX trial has been recruiting AML patients across Finland. This is a purely academical trial. It's conducted by the Finnish AML group, and the trial is evaluating if ex vivo drug sensitivity testing can be used for patient selection, identifying those patients that actually benefit from azacitidine-venetoclax combination. Can you hear me now?
Yes, perfectly.
Okay, great. So here's the key eligibility criteria and endpoints for the trial. In general, we had general eligibility criteria for all participants, and the most important being that all participants had to undergo ex vivo drug sensitivity testing prior therapy start. The blast count needed to be over 10%, either in bone marrow or blood that was used for ex vivo sensitivity testing. The leukocyte count needed to be under 25, and we needed to have adequate organ function as outlined here. We then also had cohort-specific additional criteria for non-fit participants. Basically, these are the same that were used in VIAL-A trial, with the exception of age limit, which was 70 years of age instead of 75 without additional comorbidities that was used in VIAL-A. We also had specific criteria for relapsed resistant AML, and actually this is very similar to other trials in this patient population. The primary endpoint was cumulative overall response rate, defined as CR, CRI, and morphologic leukemia-free state, MLFS, during the first 3 therapy cycles in ex vivo sensitive trial participants. The key secondary endpoint included correlation of ex vivo drug sensitivity testing with both responses and survival. Here's the trial flow for the FENEX trial. It had 2 stages, and actually we presented the first stage data at ASH in last December. So basically the trial recruited 2 cohorts. First, de novo AMLs, and to the other cohort, secondary AMLs or relapsed resistant AML patients. As mentioned, all patients underwent ex vivo drug sensitivity testing, and in the first part of the trial, all participants received AZA plus ven, regardless of ex vivo drug sensitivity testing results, and importantly, these results were not communicated to investigators. And our aim for the first stage of the trial was to evaluate if ex vivo drug sensitivity is feasible for predicting responses, and we also wanted to evaluate the sensitivity and specificity of the assay. Here is the trial workflow. So all university hospitals across Finland took part in the trial. There is 5 university hospitals where the bone marrow samples were taken, and then they were shipped to our VENEX laboratory here in Helsinki. At first, we did mononuclear cell enrichment with fecal within 26 hours of sampling. And then in parallel, we plated these cells to 2 drug plates, first utilizing ATP-based assay CTG, as Heikki mentioned, and the second on the plate that utilized flow cytometry-based ex vivo drug sensitivity testing. And importantly, we actually had 3 different medias that we explored on the flow cytometry plate: RPMI, which is, as Heikki mentioned, cytokine poor media, SFPM, cytokine rich media, and CM, stromal cell line derived medium. And after 48 hours of incubation, we had the ex vivo sensitivity results from these trial participants, and this was then correlated to in vivo responses that we observed in the trial participants during the study therapy. I will briefly discuss about the results from the first stage of the trial. As mentioned, this was presented at ASH meeting last year. Altogether, 41 participants were evaluated for eligibility. And all those participants, we actually did ex vivo drug sensitivity testing and observed that we were capable of producing sensitivity result for 40 out of these 41 participants. 2 of these participants had a screening failure, 1 due infection and 1 due low blast count, but importantly, these were not related to ex vivo drug sensitivity testing. We had one early death at day 14, and thus this patient wasn't evaluable for in vivo ex vivo correlation. That left us with 37 participants who were evaluable for ex vivo in vivo correlation. Here's just some numbers from the first part of the trial. We had 16 de novo AMLs, 25 patients with secondary relapsed or resistant AML, and we observed treatment responses, CR or CRI, in de novo patient population in 76% of the patients, and in secondary relapsed resistant AML population in 39% of the patients. And as mentioned, the ex vivo testing was successful in 40 out of 41 participants, giving a success rate of 98%. And Heikki will continue here. Go ahead, Heikki.
And then a couple of words from technical details. So the criticism that we many times hear as a functional testing people is the shape of the cells and the viability. So right after processing, we analyzed the viability of these samples. The viability was 90%, and after 2 days of incubation in conditioned medium, it was 75%. And then the next question was that, does it matter that if we process the cell right away or then kind of the next morning? So those samples that we got from the university or Helsinki University Hospital were processed right away. That means within 6 hours. And those samples that came from the other hospitals were shipped to us on the same day. And they arrived at the evening, but we didn't want to do night shifts. So we processed these samples the next morning. And the viability was slightly worse for those samples, both at day 0 and day 2. But as a conclusion, we think that we can still kind of use these samples after 24 hours. The viability is relatively good. And then next we ask that whether this viability is associated with the venetoclax responses, and we didn't see any correlation with the viability responses as shown here. Then we tested the blast-specific viability with flow cytometry in 3 different media, and as expected, the blasts were most sensitive in the RPMI, and the sensitivity was smaller in the conditioned medium, but there was a drastic kind of decrease in the viability of these to venetoclax when they were culturing this SPM medium. And there is a dose response curves or average dose response curves of these 39 tested samples in different medium. And as you can see that the IC50 in the RPMI is 2.9 nanomolars, but in the SPM it's over 1000 nanomolar. So there's a huge difference in the venetoclax sensitivity, differing that what kind of cell culture medium we are using. But then the interesting question was that which of these media predicts the clinical responses the best. And the biggest kind of separation between responding and non-responding patients were observed with the conditioned medium when flow cytometry were used, and when we used RPMI or SPM medium, the difference wasn't so big. And for example, in SPM medium, many of those blasts that actually the patients responded to a treatment were ex vivo resistant. And then because of these patients were treated also with ven-azacitidine combo, we tested a combination, but it didn't show good separation. And then we also tested the bulk sample sensitivity with CTG, and I will come back to this topic a little bit later. But by using blast-specific measurements in conditioned medium, the ROC curve AUC was 0.82, and by using a cutoff value of 10.7, as shown in the left side picture, 23 out of 26 ex vivo sensitive patients responded to treatment, so the positive predictive value of the test was 88%. and negative predictive value 82%. And next, we analyzed the two patient cohorts separately. So treatment naive de novo AML patients, actually all except one patient were a treatment response. And we have two false predictions of resistance. So for this patient cohort, we thought that this kind of testing doesn't bring additional value, or it has limited additional value. And for the relapse refractory cohort, all of those patients that were predicted to be resistant actually were also clinically resistant. And in addition, that this drug-sensitive testing was able to predict treatment responses. It also was strongly associated with overall survival. So for ex-resistant patients, the overall survival was 3.5 months, and for ex-vivo sensitive, 13.1 months. And now going back to that CTG measurement. So as you can see in the left side picture, so almost half of the samples were highly resistant when the bulk sensitivity was measured with CTG in condition medium. But in these same samples, there were many times blasts that were actually highly sensitive. And what we have observed also earlier, as you can see in the B figure in the scatter plot, that in those samples, when there are granulocytic or monocytic cells, the blasts get killed ex vivo with venetoclax, but nothing really happens to these granulocytic and monocytic cells. And if the sample has kind of low blast count, it usually means that there is other cells like lymphocytes, monocytes, and granulocytes. So next we kind of divide our patient cohort to two. So those patients who has blast count less than 50% and 50%. And majority of the patient with low clinical blast count were ex vivo resistant to venetoclax, but with the flow cytometry, half of these patients or more had blasts that were sensitive to venetoclax. And then there has been discussion on the monocytic AML, particularly in the FAB-M5 AML. So whether it's a poor prognostic marker, venetoclax, ASA response. And in first stage, we had 4 patients with FAB-M5 AML and 1 patient with FAB-M4 AML. And when these were measured with CTG, they were all ex vivo resistant, but 4 out of those patients, we were able to identify CD34 or CD117 positive blasts, which were sensitive. And actually all of those 4 patients also went into remission. And then we performed single-cell RNA sequencing for 3 of these samples, and we identified kind of 6 different main leukemic clusters. And all of these samples had CD34 positive cells, which is that monocytic 1 cluster. It comprised 25 to 50% of all of these samples. And if we concentrate on the monocytic 1 population in the balloon plot and start from the left, so we can see that they don't express CD34, they express CD14. They also highly express BCL2A1, MCL1, but they lowly express BCL2. And also they have high expression of S108, A8, and A9. And then if we go to myeloblast 2 compartment, so they are CD34 positive cells, and they express BCL2, but don't express these other genes so highly. And now if we tested these samples with CTG and analyzed the bulk RNA sequencing, it has led us to a resistant phenotype linked with high CD14, BCL2A1, S108A expression. And based on this limited patient cohort we have here, we think that it's probably not so relevant in this or clinically. And we kind of think that particularly in those samples which have low blast count, or in these monocytic samples, one should really focus on the blast cell population or progenitor cell population when doing drug screening, RNA sequencing, proteomic analysis, and so on.
Thanks, Heikki, and I will then continue to the whole trial results. The trial recruited patients actually starting from February 2020, and we stopped the recruitment in May 2022. As you remember, as mentioned in the first stage, all participants received combinational therapy, but for the second stage, actually, for de novo participants, as Heikki mentioned, they were all receiving AZA plus ven because the treatment responses were so good. But for those participants that had secondary or relapsed or resistant AML, we actually used ex vivo drug sensitivity to patient selection. And those participants that exhibited ex vivo sensitivity were included to trial therapy, whereas those participants that were ex vivo resistant were excluded from the trial therapy, but were subjects for later follow-up and collection of survival data. And the second part of the trial recruited altogether 65 participants. Just to show that basically, of course, what is known that for de novo AML, the treatment responses and survival is better. For our cohort, it was 17 months, whereas for relapsed, resistant, or secondary AML patients who received study therapy, it was 9 months. Again, also in this whole trial cohort, we were able to show that ex vivo venetoclax sensitivity predict survival. For ex vivo sensitive patient, the survival was approximately 15 months, whereas for ex vivo resistant patients, it was approximately 4 months. We next performed a univariate analysis to see what factors actually contribute to the responses. We observed that previous treatment, in this case, secondary relapsed or resistant AML, was associated with a lower number of responses, as well as that was seen with complex cytogenetics, of course, were a very well-known risk factor. I think quite interestingly, we were able to show that ex vivo venetoclax sensitivity was by far the best predictor for treatment response for these participants in the whole trial cohort. I will next concentrate on previously treated AML, meaning relapsed, resistant, or secondary AML, due to the fact that this is actually the currently most difficult to treat patient cohort, and perhaps one could say that unmet medical need. For this patient population, in those participants that were ex vivo sensitive, the CR/CRi rate was 62%, and altogether 82% of these patients actually gained treatment response. And also for the relapsed, resistant, and secondary AML population, we can see that ex vivo sensitivity predict treatment response, and overall survival for sensitive patients was approximately 9 months, whereas for resistant patients, it was 3.5 months. As you remember, in the first stage of the trial, ex vivo resistant patients with secondary relapsed or resistant disease also received AZA plus ven, whereas in the second stage of the trial, these participants were excluded from the trial therapy. So we next asked, is there any difference between the prognosis in these two patient groups, both ex vivo resistant, but another group receiving AZA plus ven and another group didn't receive the study therapy? And then when looking at the overall survival, actually these survival numbers are extremely similar for treated patients 3.5 months, and patients not receiving therapy 2.3 months, perhaps giving additional proof that ex vivo drug sensitivity testing can predict treatment outcome in this patient population. We next looked at the mutations in the relapsed resistant patient cohort and observed that some of the mutations that have been linked with responses, for example, IDH2, SRSF2 mutations, also in this patient cohort were linked to responses, whereas complex karyotype TP53 mutations and PTPN11 mutations were linked to lack of responses. But importantly, we have several mutations that we actually have no predictive value. And in that sense, it's important to underline that from those patients that were ex vivo sensitive, 62% of the patients had CR/CRi responses, and that altogether 82% of the patients responded to therapy. With that, we want to conclude that, first of all, ex vivo drug sensitivity testing was feasible with 98% of success rate. Experimental conditions had considerable influence on the predictive value, as Heikki outlined previously. And with blast-specific ven sensitivity, we had a high correlation with responses and survival, and the positive predictive value was 86%. And in the second stage of the trial, I think we have been capable of demonstrating that this assay might be feasible for selecting relapse-resistant or secondary AML patients to ven-aza therapy. We want to thank our funders, and we certainly want to point out that this trial has been excellent collaboration between translational scientists and clinicians across Finland. Altogether, as mentioned, this trial has recruited 104 participants. And then I certainly want to thank our core Venex lab, Ida Vänttinen, Tanja Ruokoranta, Sari Kytälä, and most importantly, Heikki Kuusanmaki, who has been a key person developing the method and making the trial actually possible. And of course, I want to thank the university hospitals and Venex trial participants and their families for trial participation. And with that, I think we are happy to take any questions.
Thank you. Thank you so much. Very, very exciting presentation and data. So we're open for question. And maybe I'll start with a curiosity, I guess. In that very first part of in the first part of your trial, you mentioned you had 41 patients, right? But only 40 you were able to perform testing on. I was wondering what happened on that one extra case. It's, you know, just out of curiosity, I guess.
Yeah, I can answer. So in that one patient, we couldn't really identify CD34 or CD117 positive blast with the flow assay. And we kind of think that it was the blast percentage was very low in general, and it might be hemodiluted as well. So that was the reason.
Okay, yeah. So it's still a blast percentage type of
Yes.
of issue. Got it. Yeah. Thank you so much. We have a question in the chat from Inez. So she's saying, thank you for an interesting presentation. May I ask why the venetoclax was used in combination with aza, but not alone?
So basically, actually, perhaps Heikki can also comment on this, but most of the data was on venetoclax alone, and venetoclax alone was the best predictor for the treatment responses. We also explored different combinations, including azacitidine plus venetoclax, but the predictive value for using aza plus ven was inferior when we compared to ven alone. Do you want to, Heikki, comment on that, or?
Yes, exactly, and that's a very good question, because one would kind of hope or think that the ven-aza would predict the best. But I think that how the azacitidine works in the patient, it's still a slight mystery, whether it works through like hypomethylating effect, whether it's directly cytotoxic, whether it's immunomodulatory agent. And I think that in this kind of short essay, we can't really recapitulate what's happening in the patient. And I think that with high concentration of azacitidine, we are kind of inducing this kind of cytotoxic effects that might not be so relevant in the patient, but this is speculation.
And clinically, venetoclax is never given alone, right?
There is just phase 2 trial data on venetoclax alone. So basically, venetoclax currently is always used in combinations. And as mentioned, the most promising combination seems to be AZA plus ven. Perhaps in the future we'll see more data, or there is already existing data on the triplets, but thus far it's kind of the mainstream to use the AZA-ven combination.
Thank you so much. Other questions?
Alice, can I ask a question?
Oh, please go ahead, Diana.
Yeah, thank you. Thank you. This was great presentations. It's interesting how the experimental condition or the culture media affected the results. So do you have an understanding of why this is the case? Is it related to blasts, also percentage of blasts?
That's I think a very, very important question. That first of all, when we kind of have performed this high throughput with testing, so that especially for venetoclax and BCLers, the cell culture
You're
conditions.
breaking. Hold on. Is it just me? You are breaking. I'm sorry. I couldn't hear you.
Breaking up a little, yeah.
Yeah.
Let's try again.
Maybe I start again. So when we have performed this high throughput drugs sensitive screening with more than 500 drugs, so I want to mention that these BCL2 family inhibitors, they are the ones that are affected the most with these different cell culture conditions. So that's the first thing. And second thing, I think that when we don't have enough kind of cytokines and correct nutrients for these cells, they are primed to apoptose already. And then probably only BCL2 is holding it up, that they are not getting killed. But then when we add, they're like cytokines which can activate the JAK-STAT pathway, MAP kinase pathway. Then you add the BCL2 inhibitor there, but the cells don't die anymore because they have some alternative survival pathways. And I think this is the big challenge to kind of mimic that what's true in the patient itself. Because also I think that every patient, the bone marrow microenvironment can be slightly different. And now there's a risk that we have very, very poor medium, so everything just kills the cells, or then we boost the medium with all kind of cytokines, and we artificially kind of make them resistant to these BCL2 family inhibitors. And
yeah, thank you. We have another question. Hamad?
Thank you very much. I also have a question on this interesting, effect that cell culture has on drug sensitivity. And I guess a follow-up question to the previous question would be is, do you see that these effects of cell culture media span drugs to the whole class of category of, for example, BCL inhibitors, or are there specific drugs within the same class that could be maybe better selection based on what you see due to these effects on the cell culture media on these drug sensitivity results? I guess actually, how do you balance that, and how do you select the most optimum drug?
Sorry, what was your question? Should we kind of choose the best medium for each of the drug, or?
Well, my question first is, do you see that, for example, all drugs that, maybe example, as you put it, like target BCL and show, for example,
Yes.
more effect, are all
Yes.
equally affected, or are there like certain drugs in a class that may not be affected?
Yes, so we haven't tested with all of these medium, all of the drugs, but usually, as I showed at the beginning, so the same class of drugs, like the FLT3 inhibitors, became less sensitive in the cytokine medium. Also, the BCL2 family inhibitors become less sensitive. The same class behaves similarly. But out of the 500 drugs, 300 drugs that their kind of sensitivity or efficacy don't change depending from the medium. So it's kind of drug class specific effect in some sense.
Got it. Thank you.
Yeah, that is very interesting. Other questions? Well, I guess let me ask you a kind of a follow-up closing question. So this second part of the trial is ongoing, right? And so what's the plan next? Are you, is the test going to be approved clinically? Where are you taking this moving forward?
Thanks. That's a great question. So as mentioned, our trial recruitment has ended. Of course, we still do have quite many trial participants on trial, and then we are also collecting samples from the relapses. But as was outlined previously, this has been now kind of single-center trial in a sense that we have done the ex vivo drug sensitivity testing just in Helsinki in our venetoclax lab.
Mm-hmm.
And then we are currently starting pan-Nordic trial. So basically Denmark, Norway, Sweden are also joining. And we have, as you are aware, we have several labs across Nordics that you do ex vivo drug sensitivity testing. So our idea here is that we kind of want to see if it's can be done in a multi-center manner. And then we are with that trial also exploring a bit shorter venetoclax course due to the clinical toxicity that we observe, but at the same time we are doing an observational trial to evaluate this approach in multi-laboratory setting. So that's kind of the first step that will take our attention for next few years to run that trial. But I think that might be helpful in answering the question that can this be generalized and used in different labs and different countries.
So your choice is one to kind of have multiple labs, right, running the same assay, as opposed to sending all the samples to, I guess, a single location. Is that, also because of concerns about viability and transportability of the samples, or how did you go about this decision?
Well, I think the bottom line here was that, for example, in Stockholm and in Copenhagen and in Oslo, there has been quite vivid ex vivo drug sensitivity testing labs. So it was kind of a pan-Nordic effort to expand to those laboratories that have been doing ex vivo drug sensitivity testing. And for that reason, it was kind of a common basis for a common pan-Nordic trial.
Yeah, kind of highlights the need for a community that's of likely-minded, I guess, people to get this taken up across nations. So that's very exciting, actually. I think we're all very much looking forward to your experience and learning from it. All right. Is there any other question? Well, if not, I want to thank both of you for being with us today and presenting us some very exciting, clinical data. Thank you so much. And, we'll see everyone in a month.
Thanks so much. Bye-bye.
Bye.
Bye.